Good evening and welcome. It's my pleasure to welcome you to our Alzheimer's Society of Saskatchewan Evening of Education. Tonight's presentation will be on When Dementia is Not Alzheimer's, presented by Dr. Andrew Kurt. My name is Heather Dash, and I'm the Program Manager for the Programs and Services team for the Alzheimer's Society of Saskatchewan. As we gather here today, I acknowledge that I'm joining you from Regina, which is in Treaty 4 territory and the homeland of the Métis. The people of the Alzheimer's Society of Saskatchewan are privileged to live and work across the traditional sacred land we know as Saskatchewan. We recognize the legacy and enduring presence of the Cree, Dakota, Dene, Nakota, Lakota, Sioux, and Métis people, who are the original stewards of the rolling hills, rushing rivers, and living skies we all share today. As an organization, we acknowledge the harms of the past and how Indigenous people are still impacted by the process of colonialism. Through education, partnership, and collective action, we're committed to honoring our relationship with the land, our treaties, and each other as we journey towards reconciliation. Before we begin, I would like to take care of a few housekeeping items. First off, I would like to thank our supporting sponsors, SaskTel Telcare and SGI. The presentation tonight will be recorded. Please know that only the presenters are being shown on the screen. As participants, your faces and names will not be shown, and you will all be muted. If any attendees would like closed captionings, we have enabled the automated captions, which you can select at the bottom of your screen. If you don't see the closed captioning option, click the three dots for more options. Following tonight, an email will be sent out to you with a short evaluation survey, as well as links to resources related to tonight's presentation. During the presentation, you can type your questions for the presenter in the Q&A function near the bottom of your screen, not the chat box. We have a brief question period at the end and where the presenter will go through your questions. We ask that you keep your questions relevant to today's topic and general questions only, nothing personal. The presenter will not be giving personal advice and will not comment on a personal situation. I would like to introduce our guest presenter for this evening. It is my pleasure to introduce Dr. Andrew Kurt. Dr. Kurt is a professor of neurology at the University of Saskatchewan, where he's been on faculty since 1991. He's completed his medical education at the University of Western Ontario, followed by internal medicine training at the University of Toronto and neurology residence at Western. After residency, he pursued 3 years of research fellowship in cognitive neurology at the University of Florida and the University of Western Ontario. Dr. Kurt's major clinical and research focus is dementia. In 2003, he co-founded a CIHR-funded rural and remote memory clinic using telehealth to expand access to specialized care across Saskatchewan. He also established a multidisciplinary clinic for individuals with Huntington's disease in the province. He served as head of neurology at the University of Saskatchewan for 16 years. He has been deeply involved in professional leadership, including 6 years on the board of the Alzheimer's Society of Saskatchewan, and he is a past president of both the Canadian Neurological Science Federation and the Canadian Neurological Society. Dr. Kurt presented his work nationally, including the Canadian Academy of Health Sciences and Senate of Canada. In addition to his clinical and academic work, he is also a published fiction writer. He has twice been nominated for the University of Saskatchewan Students' Union Teaching Excellence Award, received the Michael Wright Community Leadership Award for the Huntington Society of Canada, and in 2012 was awarded the Queen Elizabeth II Diamond Jubilee Medal for his contribution in neurology. Please join me in welcoming Dr. Andrew Kurt. Okay, Dr. Andrew Kurt, I will stop sharing my screen so you can start your presentation.
Thank you very much, Heather. I'm just trying to get this shared. Can I ask? Oh, there we go. Okay. Can I just check, Heather? You can see that well?
Yep, it's
Good.
looking
So
good.
I'm assuming everyone else can see it too. Good. So thanks very much for the introduction, Heather. It's good to be here tonight. And it's good to talk about something other than Alzheimer's disease because that's the cause of dementia that everyone knows about. The society is called the Alzheimer's Society, when it might make more sense to be called the Dementia Society, but for historical reasons, that's the name that everyone recognizes. This is Eos, the Greek goddess of the dawn. The Romans called her Aurora. And there's a story told that goes back almost 3,000 years that she fell in love with a young shepherd by the name of Tithonus. Now, she knew that she was a goddess, she would live forever, but Tithonus was only a mortal and he would someday die. So she asked Zeus, I guess it pays to have friends in high places. She asked Zeus if he would make Tithonus immortal. And Zeus granted this wish. But what she didn't ask him was to keep Tithonus young. So while she stayed forever a young, beautiful goddess, Tithonus became older and older and developed more physical problems. And then eventually, when you read it, he developed dementia. And she tried for as long as she could to look after him, but it eventually proved too much, even for a goddess. And there are two different endings to the myth. In one of them, she puts him in a cave and rolls a big stone in the entrance and just leaves him there forever, babbling endlessly, words with no meaning. And in the other one, she changes him into a grasshopper. Now, neither of those is a very good treatment for our patients nowadays or for people with dementia. But if we fast forward to the very beginning of the 20th century, this is a woman called Augusta Detter. And she was a woman in Germany. She's only 52 years old when this photograph was taken, but she began to develop memory problems. She became paranoid. She accused her husband of having affairs. She started making a lot of noise in the night, and the neighbors were complaining. So she was taken to see this gentleman, Dr. Alois Alzheimer. And he examined her and diagnosed her with some form of dementia. He didn't really know what it was. And she unfortunately never left hospital. A few years later, when she died, this isn't actually her brain, but a normal human brain on the left, and then a brain that hers might have looked at on the right hand side, a brain that's very shrunken. And when he looked at it under the microscope, he saw two things. He saw these little tadpole shaped things that are neurofibrillary tangles, and he saw these big blobs that are amyloid plaques. And so she was the first person to be diagnosed with what came to be known as Alzheimer's disease. And this is what really started the modern interest in cognitive disorders, in dementia. So I said we weren't going to speak about Alzheimer's disease, and we're going to leave it alone in just a moment, but I'm going to say a couple more things that have to do with Alzheimer's disease. First of all, what is dementia? Let's start with a definition. So this is an old definition by Cummings and Benson, but I think still a reasonable one. So it's an acquired, it's not something you're born with, it's something that you acquire as you go through life. Persistent, so it's not something that bothers you for a few days, it's something that bothers you for a long time. Impairment of intellectual function with compromise in at least three of the following spheres of mental activity: language, memory, visual spatial skills, emotion or personality, and cognition, including abstraction, calculation, judgment, and so on. So that's the general term, dementia. That's essentially what it means. And there are different definitions, but I'm partial to this one. How common is dementia? Well, the Canadian Study of Health and Aging back in the 90s demonstrated that about 1 in 12 people over the age of 65 has some form of dementia, and a pretty staggering 1 in 3 people over the age of 85. And then, of course, they were only looking at elderly people. We see people with dementia well under the age of 65. Some forms, like frontotemporal dementia, for example, often affect people in their 50s and sometimes in their 40s. If we look not even at the human emotional day-to-day toll on people with dementia and their caregivers, if we just looked at the financial cost of dementia, it's estimated that last year in the world, to directly care for people with dementia, we spent US $1.313 trillion. So it's hard to fathom what a trillion is. But let's say dementia, the amount we spend on dementia was the GDP of a country. Then last year, dementia would be the 14th largest economy in the world, right between Australia and Spain. So that's pretty staggering. Even when we just look at the financial cost of dementia, it's huge. So we're going to leave Alzheimer's disease in a moment, but I do want to say a little bit more about it. So typically in Alzheimer's disease, memory problems are the problems that are dominant early in the illness, and they remain dominant as the illness progresses. They're often followed by other problems like trouble finding one's way and personality changes and things like that. But usually, not always, but in most people with Alzheimer's disease, memory is the early problem, and it remains a big problem throughout. We also, though, see people with mixed dementia. So these are people who fulfill the diagnostic criteria for typical Alzheimer's disease, but they also have clinical or brain imaging evidence of another disorder, the most common one being vascular. So we see a lot of people with mixed vascular / Alzheimer's dementia. Lewy body disease is also another one. Most people with Lewy body disease also have Alzheimer's changes in their brain. So I just wanted to mention Alzheimer's disease, and then the rest of the talk, we're not going to talk about Alzheimer's disease, but I just wanted to introduce the concept of mixed dementia. We can see people who have Alzheimer's and vascular dementia. You can see people who have Lewy body disease and vascular dementia. So we can see mixed dementias. How common are the different types of dementia? So are we talking about really rare things or what? So if we take 100 people with dementia, and these numbers don't really add up to 100 unless you pick the smaller of one and the larger of another, but because there are ranges taken from different studies. So roughly 60 to 80% of people, of the 100 people with dementia will have Alzheimer's disease. Roughly 10 to 20 will have vascular dementia, roughly 10 to 20 will have Lewy body dementia, and around 10 will have frontotemporal dementia. There are lots of other causes of dementia that are quite uncommon, but these are the big common causes of dementia that we see all the time. And how do we decide if someone has vascular dementia or mixed dementia or what? Well, for each of these illnesses, I'm going to give a chart like this that kind of shows you some of the essentials, and then we'll explore it a little bit further afterwards. So vascular dementia is less common as a sole cause of dementia than Alzheimer's disease is, as I just said. It's caused by problems with blood vessels leading to either bleeding in the brain or blockage of blood vessels causing what's called an infarct. So there are two types of stroke, two basic types of stroke. One is a hemorrhage, which is due to a bursting of a blood vessel and bleeding in the brain. The other is an infarct, which is due to a blockage of a blood vessel in the brain that leads to the death of that part of the brain that was supplied by that blood vessel because not getting oxygen and blood. Two main types of infarcts. One is a lacoon, which is a very small infarct deep in the brain. And you see these most often in people who have diabetes and or high blood pressure. And then there are large vessel infarcts. And these are blockages of large blood vessels. As I said, vascular dementia is very common as a mixed pathology with Alzheimer's disease. Some of the symptoms that may be more common in vascular dementia may be problems with impaired judgment, ability to make decisions, planning or organizing, and these are frontal lobe abilities. And so it's typical to see more frontal lobe changes in people with vascular dementia, but vascular dementia can look an awful lot like Alzheimer's disease clinically in terms of the symptoms and so on. It often coexists with Alzheimer's disease. People may have Alzheimer's disease and also have a stroke, where we would talk about mixed dementia. And on MRI scan, or CT scan, we may see evidence of strategic infarcts or a lot of infarcts. So I talked about some different types of vascular dementia. So we can have multi-infarct dementia, where people have just had a number of fairly large infarcts in the brain, that is blockages of large blood vessels causing damage to the brain. We can have strategic infarct dementia, that is one stroke that's in a part of the brain that's so important that it results in dementia. And a very common place for that is in the thalamus. And I'll show you, that's a structure deep in the brain that controls a lot of things. People can have a lot of lacunes, those tiny little strokes deep in the brain that are common with high blood pressure and diabetes. Not everyone who gets them has high blood pressure and diabetes, but they do raise the risk of that. And you don't develop dementia from one lacune. For some reason, my slides keep going forward if I talk too long. Maybe they're impatient and want me to hurry up, but I'd rather take my time. But you can get dementia if you have lots of lacunes because they're all causing a little bit of damage as they happen. Or we can have bleeding in the brain. We can have hemorrhages. So just to show you what some of these look like, this is someone with multiple infarcts. So on the right side of the picture, towards the top, which is the front of the brain, you see a black area. That's one infarct. And then on the right side of the picture, towards the bottom, you see another big black area. That's another infarct. And on the left side of the picture, we see a big new infarct. Those two black ones are old, and then there's a new one on this side. So this is someone who's had a number of strokes and might well have vascular dementia. I talked about strategic infarct dementia. So the arrow here is pointing to a relatively small infarct deep in the brain in the thalamus. And this is someone who might develop dementia just because the thalamus is so much is concentrated in the thalamus that sometimes one stroke can result in widespread cognitive changes. This is someone with lots of lacunes, lots of changes in the white matter of the brain who might have dementia. And this is someone with multiple hemorrhages in the brain. These white areas are hemorrhages. Now, one of the things that is often different about vascular dementia is the way it progresses. So most forms of dementia, like Alzheimer's disease, Lewy body, frontotemporal, the ones we're going to talk about, tend to progress in a gradual fashion. So people with Alzheimer's, typically it creeps up on them very slowly, and then it gradually gets worse over time. Some people, it gets worse rather faster than others, just depending how rapid the pathology is, but it tends to be gradual. An exception to that would be if someone gets sick with something else. So it's not uncommon where we see someone with Alzheimer's, say, who's been going along, they've been gradually getting a bit worse, and then they get pneumonia or something like that. They end up in hospital, or a bad urinary tract infection. They get sick, they end up in hospital, and they get delirious from that illness. They get worse and often don't bounce back to the way they were before. So sometimes we can see these sudden changes in people with Alzheimer's and other forms of dementia. But those sudden changes can be common in people with vascular dementia. And that makes sense because if it's due to strokes happening, we can see someone who's going along at a plateau, they're pretty stable, and then they have another stroke, so they get worse. Then maybe they have some recovery over time, and then they have another one and they get worse. So in vascular dementia, often it is just a steady progression over time, but we can see these long plateaus where they don't change, and we can see this sort of stepwise change that isn't typical of other dementias like Alzheimer's disease. So they're going along, they get worse. They're going along, they get worse. Stepwise or fluctuating course, where they get a bit worse and then over time they get a bit better and then they get a bit worse again. So that can be one of the hallmarks of vascular dementia. But some people with vascular dementia, it is just a steady decline, as it tends to be in Alzheimer's, frontotemporal, Lewy body, and so on. So treatment of vascular dementia, well, the mainstay of treatment of vascular dementia is preventing further strokes. So that may be treating high blood pressure, treating diabetes, treating other risk factors, using aspirin, which is a blood thinner, or other types of blood thinners or anticoagulants, depending on the cause of the stroke. So that's why when someone has a stroke, they tend to get admitted to hospital and treated for that stroke, but also investigated what was the cause of this stroke and what is the best treatment to prevent the next stroke from happening. And so we always try to lower the risk of stroke. We can never lower it to zero. So unfortunately, people are at risk of having strokes in future. And if you think about it, so for example, in people with lacunes, those small strokes that are throughout the brain, by the time they have their first lacune that they notice, they may have lots of others that they haven't noticed because they're in fairly quiet parts of the brain. And this is due to narrowing in the tiny blood vessels deep in the brain. And so by the time you've had a few lacunes, your blood vessels, your other blood vessels are already very narrowed. So even if you do everything right, you unfortunately may go on to have further lacunes. So vascular dementia is a bit less predictable than the other types because people may, if they've had a couple of strokes, the cause is found and they're put on an effective preventive treatment, they may remain quite stable. In other cases, depending on the type of stroke, they may get worse. The cholinesterase inhibitors, which are medications that increase the amount of acetylcholine, which is a normal transmitter in the brain, it's used in Alzheimer's disease, but it also, many people with vascular dementia may respond to these medications as well. So these are things like donepezil, ribostigmine, galantamine, trade names Aricept, Exelon, Remenil. They may help some people with vascular dementia. They help a lot of people with Alzheimer's disease. It's less predictable, the benefit in people with vascular dementia, but it's often worth a try to see if it helps. So we've talked a bit about vascular dementia, and unfortunately, because we have limited time, I could give a talk for an hour about vascular dementia or about Lewy body dementia or so on, but we have to keep moving on. So the people who are dealing with vascular dementia were interested in that part. Now the people with Lewy body dementia who are interested in that and want to hear about that, their ears are perking up a bit. So the pathology in Lewy body disease, I talked about the amyloid in Alzheimer's disease. In Lewy body dementia, it's a different protein. It's a protein called alpha-synuclein that develops in the nerve cells, the neurons, and it affects the cortex of the brain. This is the same protein that accumulates in different parts of the brain in people with Parkinson's disease. So it has, as you'll see, some common features with Parkinson's disease. People with Lewy body disease are often likely to have sleep disturbances early or even long before they develop the illness. So there's something called REM sleep behavior disorder, which some of you may have heard of, some of you may have experience with. In REM sleep, that's when we're dreaming. It stands for rapid eye movement. So during REM sleep, our whole bodies, all our muscles are supposed to be paralyzed except for our eye muscles and our inner ear muscles. So that's why they call it rapid eye movement, because our eyes are moving all around, all over the place, but the rest of us is paralyzed. In some people, that paralysis doesn't work. And so their body is not paralyzed while they're dreaming. And instead, they're acting out their dreams. And they may be violent dreams. They may be fighting. I remember seeing a young man once who had this, and he came in with his girlfriend, and her arm was in a sling. He had broken her arm in his sleep. And I said to her, you must really love this guy, because he must have some redeeming qualities because he broke your arm. And of course, the poor guy felt terrible about it. He couldn't help it. He was asleep. So often people will have REM sleep behavior disorder, sometimes for years, sometimes even for decades, before they ever develop Lewy body disease or Parkinson's disease. It's also a risk factor for Parkinson's disease. Now, not everybody who has REM sleep behavior disorder develops Parkinson's disease or Lewy body disease, but it is a risk factor, and some people do. Hallucinations, fluctuating symptoms, sensitivity to antipsychotics. We'll talk about these in a bit more detail. Gait changes, slowness, stiffness, which we see in Parkinson's disease as well. Tremor is seldom prominent. So in Parkinson's disease, the tremor is often very noticeable, something like this, but the tremor tends to be minimal or absent in people with Lewy body disease. So you need to distinguish it from Parkinson's disease with dementia, which is another form of dementia. So people who have Parkinson's disease for years will sometimes eventually develop a dementia. The difference in Lewy body disease is that the Parkinson's type symptoms and the dementia type symptoms come on around the same time. Whereas in Parkinson's disease with dementia, they've had Parkinson's disease for a long time without dementia, and then they start to develop dementia. And I mentioned earlier that a lot of people, most people with Lewy body disease often have some Alzheimer's pathology in the brain as well. So how do we diagnose Lewy body disease? Well, you can use criteria like this. First of all, the people have to have dementia, which can be rather similar to Alzheimer's disease, memory problems. People with Lewy body disease may have more visuospatial problems, so that is trouble finding their way and things like that, than is typical in Alzheimer's disease early on. And then it's said that if you have two of the next three things that you can say this is definitely Lewy body disease, 1 out of 3 would suggest possible. So fluctuating cognition. And I don't mean the fluctuation over long periods of time that we can see in vascular dementia, but fluctuation over hours or even sometimes minutes. So most people with Alzheimer's, early Alzheimer's disease tend to be more or less the same all the time. Sometimes as the illness advances, they can get worse in the evening and things like that. But early on, things tend to be rather similar. In Lewy body disease, a person may seem almost normal at 10 a.m., but by 11 a.m. be barely conscious, totally out of it. And so you see these sort of fluctuations through the day. That's typical of Lewy body disease. Another thing that's typical of Lewy body disease is visual hallucinations. And sometimes when I ask people about that, they're surprised. They say, yes, how did you know? Because it's a strange thing, and sometimes they haven't told people about it. But often, these can vary a lot, but often they can see children or animals. Sometimes they see adults. Typically, the hallucinations don't move. They don't talk. They may move, or they may just stand still. It's unusual for them to say anything. Sometimes people realize they're not real. And sometimes they think they are real. So they look outside, they see there's a dog out on my lawn. Another person looks to say, I don't see any dog out there. I remember one lady who thought the hallucinations were real, and her daughter came over one day and she had all these blankets on the floor all over her living room. And her daughter said, what are all these blankets for? I said, it's for those little girls that were here last night so they could sleep comfortably. And of course, there were no little girls. So visual hallucinations are common. And then, as I mentioned, features of Parkinson's disease, that is a stiffness, a slowness, a change in walking, not typically tremor. Some people have a bit of tremor, but it doesn't tend to be as prominent as in Parkinson's disease. Other features that are supportive of Lewy body disease are falls. And that makes sense. If you're stiff and slow and have an abnormal gait, you may be prone to falling. Syncope or fainting, because often people have a drop in blood pressure when they stand up in Lewy body disease and in Parkinson's disease, for that matter. These illnesses are kind of cousins. And I don't know why my slide keeps going forward like that. I apologize for that. Neuroleptic sensitivity. And what that is a real sensitivity to the older antipsychotic medications that aren't used much anymore. Drugs like Haldol, haloperidol, chlorpromazine, things like that. They don't get used much anymore. They've been replaced by newer antipsychotics. But people with Lewy body disease could receive 1 dose of Haldol and be frozen in bed for days. And in fact, back in the 90s, when Lewy body disease was really just starting to be recognized, I would sometimes get a call from a referring doctor who said, I have this older man, I think he has Alzheimer's disease, but he was having hallucinations and I gave him Haldol and he's been frozen for the past 2 days. And right away over the phone, I would say, it sounds like he's got Lewy body disease. And this was when it was just being described, and the doctor would say, well, what's Lewy body disease? Now doctors know about Lewy body disease. That has changed, but I remember back in the 90s that would often happen. Visual hallucinations are the typical hallucinations that people with Lewy body disease have, but they can have other types of hallucinations. Occasionally, they can hear things. I remember one patient who used to say he felt as if a dog or a cat would brush against his leg, and he would look and there was nothing there. So he was having tactile hallucinations. There's the Lewy body, that sort of pink thing right in the middle of that cell. That's what it looks like. So that's a collection of alpha-synuclein in the nerve cells. So treatment of Lewy body disease, as in Alzheimer's disease, and as in many people with vascular dementia, cholinesterase inhibitors may help, Aricept, Remenil, and so on, the things that I talked about earlier. Medications for Parkinson's disease, like levodopa, may be considered if the Parkinson's symptoms are severe enough, but we really need to use them with caution for a couple of reasons. In people with early Parkinson's disease, they go on levodopa. It's almost a miracle. They get so much better typically, and the drug really works well. People with Lewy body disease sometimes respond well, sometimes they respond a bit. often they don't respond at all. So the levodopa doesn't work as well for the movement problems in Lewy body disease as it does in typical Parkinson's disease. And the reason we have to use them with caution, so if the Parkinsonian features are very mild, I wouldn't use them. If they're severe enough, we could consider them. But the reason we have to use them with caution is that they may make hallucinations and delusions worse. So hallucinations is seeing things, and delusions thinking things that aren't true. So sometimes they think that, you're not really my husband. You look like my husband, but you're not. You're the other guy who looks just like him. And, where's my real husband? So, or my house has been sold and moved somewhere else, and this isn't really my house. Things like that, delusions. And when the hallucinations and delusions are bad enough, we may try an antipsychotic medication. Now, I already said that these people are very sensitive to antipsychotics, and those are the older antipsychotics like haloperidol and so on. But the newer drugs like quetiapine, they're not that new, but they're newer. Quetiapine, olanzapine, brexpiprazole, things like that may be helpful with hallucinations and delusions. But we don't, if someone comes in and says, oh, I see children in my yard and they don't really bother me, and I know they're not real, and I actually don't mind watching them play, I don't treat their hallucinations because it's not a problem. But if they've become frightening and really scary and they're really bothering the person, then it's time to think about treating the hallucinations with some medication, or the delusions as well. Again, if the delusions are very mild and the person can easily be talked out of them, we might not need to treat. But we consider treatment when they're really bothersome enough that they need treatment. Let's move on to another type of dementia, frontotemporal dementia. So in frontotemporal dementia, we see shrinkage of the frontal lobe, which is at the front of the brain, so it's a good name for it, and the front part of the temporal lobes are shrunken. We tend to see changes in personality and behaviors, and we'll talk more about that in more detail. We often see difficulty producing language, and memory is typically spared in the early stages of the disease. It often comes on at a younger age. So Alzheimer's disease can come on at many ages, but typically the average age is sort of early 70s in Alzheimer's disease. Lewy body disease comes on a bit later on average, so average age would be sort of late 70s. Frontotemporal dementia, again, can come on at just about any age in later adult life, but it tends to be a younger age than Alzheimer's disease. So we often see people in their 60s or in their 50s, often people who are still working. I mean, Alzheimer's disease can come on at that age, but that's not as typical, it's not the average. So frontotemporal dementia tends to affect people who are rather younger than people with Alzheimer's disease. Here's a brain of someone with frontotemporal dementia. The front part of the brain is on the right. And you can see towards the back of the brain on the left, you see these nice plump gyri, the parts of the brain. Whereas at the front part of the brain, we see that the gyri are all shrunken, and those are described as knife-like because they're so narrow and shrunken. So 3 types of frontotemporal dementia: the behavioral variant of frontotemporal dementia, progressive non-fluent. I don't know why my slides are doing that. It's driving me crazy. It's probably driving you crazy too, so I apologize. Progressive non-fluent aphasia and semantic dementia. And number 2 and number 3 are types of dementia that affect language. So let's delve into those a little bit more. So the behavioral variant of frontotemporal dementia, there's an early decline in social interpersonal conduct and an early impairment in regulation of personal conduct. And the reason we say early is that people with a more advanced dementia, like Alzheimer's disease, may have these problems too. But in behavioral variant FTD, they come early. Emotional blunting, loss of insight. So most people with behavioral variant frontotemporal dementia don't really see that there's a problem. But their behavior has really changed. They often lose interest in other people. Because they tend to be younger, they may still have kids at home. And, I think of one man who used to be very active playing with his kids. He'd play catch with his son every evening in the backyard, but he just lost interest in this. He lost interest in his son, didn't really care much about him or anyone else anymore. It's always individual patients that you remember. And, I remember many decades ago, a patient who had been banned from the local shopping mall. He had been a pillar of the community, but now he was banned from the shopping mall for a couple of reasons. One is he had really developed a craving for sweets, and this is something you sometimes see in behavioral variant frontotemporal dementia, and people sometimes gain weight because they really have a dietary preference change and they really crave sweets. But he craved sweets. He'd carry candies around in his pocket and he'd offer them to people in the mall. And if they didn't want them, he'd run after them and try and put them in their pockets. And he also was making inappropriate sexual remarks and advances towards the women working in the shops. And his poor wife was mortified because he had never behaved like this in his life. And he didn't see anything. He couldn't even see that there was anything wrong with the way he was behaving, even when you talked to him about it. Do you think that's appropriate? It seems okay to me. So that's the sort of thing we may see in frontotemporal dementia. They may eat off other people's plates. They may, which is something you might see someone on someone else's plate in a restaurant and think that looks good, but you don't reach out and grab it and start eating it. That's something that someone with FTD might do. They may make inappropriate comments in public that they wouldn't have made before. Sometimes people who never swore will start swearing. They may make inappropriate sort of risque remarks in people who wouldn't have said things like that before. So you really see a change in the person's personality. That's behavioral variant FTD. If we move on to the language types of frontotemporal dementia, let's talk about progressive non-fluent aphasia. So these people have non-fluent spontaneous speech. And what I mean by non-fluent is that their speech is not the normal flow of speaking that, you can think of it as words per unit time. So in the course of a minute, I'm saying a ton of words. People with non-fluent speech are not saying very many words. So they speak slowly, like that. So there's lots of gaps between the words. They don't say as many words. And they have problems with grammar. They also have some troubles with understanding grammar. So for example, looking at pictures, they have a hard time distinguishing between something like the boy is chasing the dog and the boy is being chased by the dog. Those sound the same to them because they have trouble understanding those grammatical words. They may have phonemic paraphasias. That's a bit of a mouthful, but a paraphasia is saying the wrong word. And a phonemic paraphasia means saying a word that sounds like the right word. So for example, they may call a cup a tup. They've changed a sound in the word and said a wrong word. And they may have an anomia, that is trouble coming up with words, trouble naming things. And that's something we test in the office. What is this thing called? What is this thing called? Here's an MRI scan of someone with progressive non-fluent aphasia. So for reasons only known to radiologists, the left side of the brain is on the right side of the picture and the right side of the brain is on the left side. So this over on the right-hand side of the picture is the left side of the brain. And we can see this big black area there is shrinkage of part of the left frontal lobe. And the progressive aphasias are affecting the left side of the brain because in the vast majority of people, that's where language is. So here's a video of someone with progressive non-fluent aphasia, and I'll just play this.
I used to do presentations and talk to the staff. At times, that's all gone now.
Primary progressive aphasia is the term we use to refer to a set of dementias that affect a person's ability to use language. Progressive non-fluent aphasia, which is also known as the non-fluent agrammatic variant of PPA, is a disorder of expressive communication. So it either affects a person's ability to produce speech or it affects their ability to use grammar appropriately. And it can affect people in terms of how they speak and also in terms of how they write as well.
It affects the telephone most, and I used to wave my hands about and facial expressions. I can't do anything like that on the phone.
The person might notice that their speech is becoming more effortful, it's becoming harder for them to produce words. They might notice this particularly in high pressure situations.
Having previously done speeches and presentations, Bill struggled to start with. It was very frustrating for him.
Progressive non-fluent aphasia it falls within the wider group of dementias known as the frontotemporal dementias. So we know that the same proteins that are involved in frontotemporal dementia are involved in progressive non-fluent aphasia.
Bill has been a member of the Rare Dementia Support Group for about 2 years now. The group have supported Bill extremely well in various areas because you've got like-minded people and everybody shares their experiences, and they've had speakers that have been particularly good in various areas.
I've got a dietitian who keeps me fit. I go to speech therapy and they come up with strategic things that I can do on the telephone and how to run my life.
As he's become more confident, it's just a case of being a little more patient.
They understand how I am doing. I get the message across. I used to do.
You can see this gentleman who
I
has
used to
progressive non-fluent aphasia, how his speech is non-fluent. The researcher in the video there talked about the protein, and I talked about the protein in Alzheimer's disease being amyloid, in Lewy body disease being alpha-synuclein. In frontotemporal dementia, tau is the usual protein that's affected. So it's a different protein in each of these different illnesses. And by the way, I don't know Bruce Willis. I've never met him. I've never examined him. But just from what I've read in the news, it certainly sounds like that's what he was diagnosed with, was progressive non-fluent aphasia. So don't say that I said for sure that's his diagnosis, but that seems to be what Bruce Willis has from what I've read about him. The third type of frontotemporal dementia is semantic dementia. Semantic means having to do with meaning. So meanings are being lost. And I've had patients say to me, I'm losing my meanings. They just can't think of the meanings of words. So their speech is not non-fluent like the man we just saw. It's not that hesitant, broken up speech. It's quite fluent, but often it's empty. It doesn't contain a lot of meaning. It doesn't make much sense as the illness progresses. They lose meanings of words, so they have trouble naming objects. They have trouble comprehending what other people say to them. I mentioned that people with progressive non-fluent aphasia make phonemic paraphasias, like tup for cup. People with semantic dementia, because they have trouble with meaning, they may make semantic paraphasias. That is a wrong word that has to do with meaning. So they may look at a cup and say, that's a coffee break, or something like that, something that is related in meaning, but it's not the right word. They often have other problems, so they may have trouble with prosopagnosia, that is trouble recognizing faces, associative agnosia, that is recognizing objects. They may have trouble matching things that they perceive and drawing things, copying things. They can usually repeat single words easily, but they have more trouble with longer things. And they can often read aloud and write to dictation, even though they don't understand what it is they're reading or what they're saying. And I remember, way back when I was in training, seeing people with semantic dementia before the coin had even been termed. So in retrospect, realizing that's what they had. And I remember seeing this one patient, and I asked her, what is a frog? And she just didn't know. She could say frog, she could write it down, but she didn't know what a frog was. And so that's a question I'll often ask people. What is a frog? Or what is an avocado? Or what is a jaguar? And they just don't know. It's not that they lose every single word. They sometimes get some right, but they have trouble with knowing what words mean. I remember one patient who was out shopping with her husband for groceries, and he said, "Should we buy carrots?" And she'd say, "Carrots? I'm not really sure what carrots are. Do I like carrots?" And so they just lose meanings of words. Here's an MRI scan. Again, the left side is on the right, for some reason known only to radiologists. And the temporal lobe here, we're looking at the brain cut through this way instead of this way it is in the other pictures. And here's the left temporal lobe, and you can see it's very shrunken. So progressive non-fluent aphasia is when the illness affects mostly the left frontal lobe. Semantic dementia is when it affects mostly the left temporal lobe. Here's another video, and let's hope you'll hear this one. You should be able to, because I've now shared this, of someone with semantic dementia. So before we start, just listen to what she says, and you'll find it's really hard to understand, but she's quite fluent. It's not that choppy, broken up speech that the other man had, but it's quite fluent, but you're hard-pressed to catch much meaning in it, and then you'll see that she has trouble with knowing what objects are.
Your hair stays nice.
Oh, buddy, it's all right. Oh, my Lord, I thought, bang, 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 bang. And I thought, oh, my God, oh, my. And I thought, I'll be darned, it's all right.
Who fixes it for you?
D.
D. Who's she?
Millie. And I saw she
Who's
said,
Millie?
Millie.
Who's Millie?
Millie.
I don't know Millie.
Oh, no, she's gone, she's gone like that. And Millie and Carol. I know Carol and Millie.
Are those your daughters?
No, oh, yeah.
I know Carol's your daughter. Millie also?
And I thought, oh, boy. And I thought, oh, my God. Oh, my, And I thought like this, oh, I'll be D.
She does a nice job.
Yeah. And I thought, oh, I'll be darned.
Okay, here we go. I'm going to show you some objects, and I want you to show me what you...
Oh, that's about the shopping center. That's a shopping center.
Would you show me the scissors?
The scissors?
Yeah.
Here?
Okay, what do you do with that? There you go. All right, you can put that down there. Would you show me the knife? Good. Would you show me the pipe? Good. How about the pen?
So you can see she doesn't get
Okay.
So
How about...
in most of these conditions, people don't make a mistake every single time, but she didn't know which one was scissors. She didn't know which one was a pipe. And when she was talking, from her gestures, it looked like she was talking about something about having her hair done. But if you just listen to what she said, it was really hard to tell what that was all about. And we'll move on here. So treatment of frontotemporal dementia, as with most of these illnesses, we don't really have a way of stopping it in its tracks or reversing it or even slowing it down. But some of the antidepressants, SSRIs like citalopram, for example, may help with some of the behaviors in some people. They don't always help. Sometimes, if people are really agitated or that sort of thing, later in the illness, things like the antipsychotics like quetiapine or risperidone may help with some of the behaviors. I mentioned quetiapine and risperidone here, which we can use in frontotemporal dementia. We really stay away from risperidone in people with Lewy body disease because it has some characteristics of some of the older antipsychotics that people with Lewy body disease don't typically do well with. Speech therapy, and the first patient there mentioned speech therapy, may be helpful. It's not going to cure or reverse things, but it can help to see a speech and language pathologist and get some tips, some strategies, as that man mentioned, of how to deal with this. The cholinesterase inhibitors, the things like Aricept and so on, don't help in FTD, and they may actually make things worse. So we stay away from those in people with frontotemporal dementia. The progression in frontotemporal dementia, again, tends to be gradual, as with Alzheimer's or Lewy body disease. And as the illness spreads through the brain, someone who started out with, say, progressive non-fluent aphasia eventually may develop other symptoms that have, like frontal lobe type symptoms that look more like the behavioral variant. So as the illness spreads in the brain, you see a wider array of problems, and things get worse. One thing I would say, though, about the people with these language variants is that early on, their behavior isn't usually particularly affected. It's more just their language. So often they remain very functional. And I've had people who can hardly speak at all with progressive non-fluent aphasia. I remember one man I saw years ago, and he was somehow getting his message across to his sons, and they were investing for him in the stock market, and he was making a killing. So this was a man who could barely speak, and yet he still could figure out how to invest in the stock market and so on. So people may remain quite functional for quite some time with these language-based types of frontotemporal dementia. So a few things just for people with all types of dementia, people with dementia and their families. Get a diagnosis. So start with your family doctor. Family doctors can often diagnose dementia, especially Alzheimer's disease. Lewy body disease is not rare in family doctors nowadays. It wasn't the case in the 90s, but nowadays family doctors tend to be very good at diagnosing Lewy body disease. Some of the language-based ones, like progressive non-fluent aphasia, semantic dementia, that aren't as common, family doctors will often want to refer to a neurologist. Learn what you can about the illness, and I guess that's what you're doing tonight, is hoping that I'm going to tell you some things that may help you. Recognize that the person's abilities are affected by the disease. They're not doing it on purpose. I mean, you know that intellectually, but sometimes it drives you crazy when you can't figure out what they're trying to say, or they're talking again about those people who are in the house that aren't really there. Don't lose sight of the person. They're still the person that they were. Explore treatment options, see what treatments might be helpful. Plan for the future. So, we all should have a will and power of attorney and medical directives and so on. But someone in the very early stages of a dementia who can still make those decisions, if those things are not in place, now is the time to do it, because the time will come when they can no longer make those decisions. Seek out help, develop a support network, and as they say on planes, put your own oxygen mask on first. So try to look after give yourself some priority too if you're a caregiver for someone with dementia. Because if you are drowning in the problems, you can't be much help to them either. So look after yourself as well, and contact the Alzheimer's Society. And I guess that's how you got here tonight. So I'm happy to entertain questions now. I will stop sharing. And we will answer some questions. Now, I'll just ask Heather, where am I going to see the questions? I think you said to people, don't use chat. So where will they appear?
It's just if you click on more, the three dots at the bottom, and you can see the Q&A. It should have, looks like we have 3 in there right now.
So someone has asked, does semantic dementia refer to Wernicke's aphasia as contrasted to Broca's? I remember that Wernicke's is full of content words, little to no meaning, while Broca's is chock full of syntactical and grammatical function words, but minimal content. Yeah, they have some similarities, but they're not quite the same. So Wernicke's aphasia and Broca's aphasia are common types of aphasia that are most commonly occur after a stroke. So in Broca's aphasia, it's in the frontal lobe, and those people are non-fluent, like the people with progressive non-fluent aphasia. They have good comprehension. And so there are similarities, but they're not exactly the same. In Wernicke's aphasia, that's when the stroke is in the temporal lobe, and those people are fluent, but what they say doesn't often have a lot of meaning in it, and they really have trouble understanding what other people say. They have trouble repeating as well. People with semantic dementia tend to repeat. So yes, there are some analogies and some similarities there, and good for you for picking that up, but they are a bit different. Now, here's another question here. A question here from someone about stroke. Can someone have a stroke, even a severe stroke, with no detectable loss of cognitive function or awareness and no personality change? Yes. So people, for example, lacunes are typical for doing this. So I've said that lots of lacunes can cause dementia, vascular dementia. But one lacune, if it's just in the right place, it may just cause paralysis, or it may just cause slurred speech, or it may just cause numbness with no real cognitive changes at all. A larger stroke typically would be associated with some other cognitive changes, or multiple strokes would tend to cause cognitive changes. But yes, a person can survive a stroke with no loss of cognition if it's the right kind of stroke. Not that there's any good kind of stroke, but some are worse than others. Now, someone said, does one of the frontotemporal dementia conditions affect personality very seriously? Yeah, so behavioral variant is the one that really tends to affect personality, whereas the language ones tend early on not to affect personality. Once they progress, and someone with an advanced frontotemporal dementia, whether it started behavioral or one of the language variants, in the end, they all kind of look the same. But the reason for emphasizing these language variants is that often language is the only problem for quite some period of time, but eventually other things happen. Someone asked about rapidly progressing vascular dementia. Yeah, so I mentioned that vascular dementia is probably the least predictable of any of these types that I've talked about, because I see some people, who've had a few strokes, they have cognitive impairment, and they don't have any more strokes, and they stay much the same for a long period of time. Whereas other people, for example, who are having lots of lacunes, and I mentioned that those can be hard to prevent, the illness may progress more rapidly over time. So it really is varied, and vascular dementia is a hard one to predict. Someone else, here's an excellent question. Can you be diagnosed with vascular dementia without suffering a stroke? There's a bit of semantics there. The answer is no and yes. So what I mean by that is that you do have strokes, but they're not always noticeable. So for example, someone can have lots of lacunar strokes, those small, deep strokes in the brain, without really noticing any particular physical symptoms, just because of where they've occurred. They haven't caused weakness, they haven't caused numbness, they just cause cognitive problems. Similarly, strokes in certain parts of the brain, even the big strokes, the large vessel infarcts that I talked about, may not be very noticeable. So I saw a person just the other day who had an old quite a large right frontal stroke, and he never knew he had it. And now he'd had another stroke on the other side of the brain, and now he had developed vascular dementia. But you may not know you've had a stroke when you are diagnosed. So that's why I say the answer is no and yes. Are lacunes and TIAs the same thing? No. Lacunes are small, deep infarcts. Infarcts are permanent damage to the brain. The brain can have some recovery as other parts take over, but infarcts are permanent damage to the brain. In the case of lacunes, they are very small areas of damage in the brain, but their effect can be cumulative. A TIA is not a permanent thing. A TIA is a transient ischemic attack. So it's a transient thing. So someone suddenly develops right-sided weakness and aphasia, and it lasts for 20 minutes and completely goes away, and then they're fine again. That's a TIA. And it's a real, if anything like that happens to you, get into an emergency room right away, because you need to find out what caused it, because it is a warning sign that a person might have a bigger stroke. So a TIA is a transient thing that gets better. A lacune is a type of stroke, which is a permanent thing. Can vascular dementia, people are asking really good questions here. Can vascular dementia cause mobility issues? Yes. Lewy body dementia affects mobility. Vascular dementia affects mobility. Alzheimer's disease early on and the frontotemporal dementias early on don't tend to affect mobility, although later on that can happen. But it's not an early symptom. But in vascular dementia, it can be very early, as can incontinence. So when you've had strokes in various parts of the brain, especially lots of little lacunes, it's affecting all the pathways that are going down to the legs, and it can cause problems with mobility. So unsteady gait can be an early symptom in vascular dementia. It does not tend to be an early symptom in Alzheimer's or frontotemporal dementia. Can dementia be not a specific type and just referred to as due to aging? I think the answer to that is no. But let me temper that a little bit. We know that our cognition changes with aging. So at the age of 70, our memory is not as good as it was when we were 30. And that's just a fact of life. Cognition does change with age. So for example, if you see a neuropsychologist and they do neuropsychological testing, they compare you to age-matched people. So they compare you, if you're 70, to other 70-year-olds. They don't compare you to 30-year-olds. So there is a change with age, but that's not dementia because the person does remain quite functional, even though their cognition is not what it was when they were younger. It's still good enough that they can, they might make mistakes. They may have trouble coming up with a word once in a while or something. I certainly do. But they don't have dementia. And so the idea that dementia is a normal part of aging is not something that we accept nowadays. There's always pathology in the brain, be it Alzheimer's or Lewy body or vascular or what. Is it common to see other symptoms in someone who has been diagnosed with vascular dementia? Yeah, and that follows up. Someone had asked about trouble with walking. Because people have had strokes, they may have weakness, they may have numbness, they may have visual problems. When we examine them, we may see signs that they've had a stroke, even though they, for example, they may not necessarily know they've had a stroke, as we talked about earlier. And so, yes, it's quite common to see other symptoms. Whereas people with Alzheimer's disease or frontotemporal dementia, typically, other than their cognition, we don't really see any other signs or symptoms on physical examination. So they don't have weakness, numbness, things like that. People with Lewy body disease have the Parkinsonian type features that I mentioned. And people with vascular disease may have signs of stroke on examining them. Someone's asked, how does one know if hallucinations are caused by dementia or Charles-Bonnet syndrome? So Charles-Bonnet syndrome is something that was described by a fellow called Charles Bonnet a long time ago. And what this refers to is people, usually older people, but not always, who are gradually losing their vision. And their vision has become quite poor. And they sometimes suffer visual hallucinations. And they usually know, they almost always know that those hallucinations are not real. I remember one man with Charles Bonnet that I saw a long time ago. He had very poor vision, but he would see this dog and it would sit on a chair near him, and he kind of liked having it there. He found it was kind of some company. He knew it wasn't real, but he liked having it there. So first of all, with Charles Bonnet, people should have quite poor vision that has come on. They generally know the hallucinations are not real. People with Lewy body disease, their vision tends to be good. Sometimes, as I said earlier, they also know the hallucinations are not real. Now, what if someone has Lewy body disease and poor vision, which certainly can happen, right? Sometimes it can be hard to tell. So sometimes if that's the only symptom, you would tend to favor it being Charles-Bonnet syndrome. Whereas if they have features of Parkinson-type findings, for example, you would say, well, this sounds like Lewy body disease, even though they also have poor vision. So there isn't really a specific test we can do and say, oh, this proves that it's Lewy body disease, or this proves that it's only Charles-Bonnet. You have to look at the context. I hope that helps answer the question. How do we best support a parent with vascular dementia who has mostly short-term memory loss? Yeah, that's hard. I think being there for them, trying to help them with things that they're forgetting, and I think this goes for people with all other types of dementia as well. I think there's a lot of specifics, and I think the Alzheimer's Society can give you lots of good suggestions and advice for how to deal with those things. It's very individual, and so I think probably someone from the Alzheimer's Society will get back to you with more specifics about that. Someone's asked, what dementia category does hydrocephalus fall into? Yeah, so hydrocephalus, it's not one of the degenerative dementias. That's why I have, so the illnesses we've talked about tonight are what we call degenerative dementias, where nerve cells in the brain are degenerating. Hydrocephalus, hydro means water, cephalus means head, so it's water in the head. Hydrocephalus is due to enlargement of the fluid-filled spaces deep in the brain, the ventricles, and that can be due to obstruction by a tumor or something like that, or sometimes it's what we call normal pressure hydrocephalus, where there's no obstruction, but the fluid-filled spaces are getting bigger. And that puts some pressure on the brain. And what it tends to do is cause problems with gait, problems with bladder function, with incontinence, and then problems with cognition. And you may recall another illness I mentioned not so long ago that can cause problems with gait, bladder function, and cognition. That is vascular dementia. So vascular dementia is much more common than hydrocephalus. So if you took, when I teach medical students, we always talk about that triad of cognitive problems, bladder problems, and gait problems. Always think about the possibility of hydrocephalus. If you took all comers, most of those people will actually have vascular dementia. And for hydrocephalus, we get some imaging, look at the brain, and see that the ventricles are very big. The problem with that is that in people with other forms of dementia, the brain is shrunken, which also makes the ventricles big. So it's a matter of degree. And there are times when it can be hard to tell, could this be hydrocephalus, or is it just because the brain is shrunken? But it's certainly something we always think about when we see people with that triad. Because it's treatable. Hydrocephalus is treatable by putting in a drain. And someone's asked, if a diagnosis of an old stroke, how can you tell when the stroke happened? So you remember I showed a scan there that showed some old strokes, which were very black. So old damage just looks, it's just like a black hole in the brain. Whereas a recent stroke that happened within the past, say, few weeks doesn't look that black. It looks, there's a difference in the intensity when you look at the brain, but it doesn't look that black. And by old, that could be anywhere from a couple of months to 30 years. After a few months, they look the same. You just see this sort of black hole in the brain where the stroke happened. Let's see. Can major anxiety potentially be the beginning of some form of dementia? We know, well, first of all, sometimes it can be hard to tell the difference between anxiety and cognitive problems, because even in a young person, if you're very anxious, that can make it hard to pay attention and to remember and so on. But we know in lots of forms of dementia, psychological disturbances are quite common. So depression is common in people with Lewy body disease, in particular, also in people with Alzheimer's. You can see it in any type. Anxiety can be common. And there's a psychiatrist we talk about mild cognitive impairment, meaning people who have early problems preceding Alzheimer's or another form of dementia, where they have mild cognitive problems, a little bit of memory trouble, but they're still very functional. And he's coined the term mild behavioral impairment to refer to people who have mild changes in behavior. So mild issues like anxiety, mild depression, and so on, that are not overwhelming. And yes, those can sometimes be a premonitory symptom of a dementia, but not always. Can severe sleep apnea cause dementia? It's a risk factor for dementia, especially Alzheimer's disease and vascular dementia, and it can cause cognitive problems. So it's important to diagnose sleep apnea, because people who are sleepy all the time tend to be rather forgetful and so on. It's hard for them to pay attention. And obviously, sleep apnea is very treatable with CPAP, with wearing a mask at night, which can be hard to get used to, but usually you can get used to it. And it really pays dividends over time. So it doesn't really cause dementia, but it is a risk factor for dementia. And it may coexist with dementia. So someone might have Alzheimer's disease and sleep apnea, and you can fix the sleep apnea a lot more easily than you can fix the Alzheimer's disease. Someone's asked, can you have a combination of vascular dementia and frontotemporal dementia? Yes. So vascular dementia can really be combined with everything. Most often we're talking about mixed vascular / Alzheimer's disease. It's not rare to see vascular / Lewy body disease. Less common to see vascular and frontotemporal. And one reason for that is that the people with frontotemporal are often younger. And the younger you are, the less likely you are to have vascular disease and stroke. But it certainly can happen. Are there strategies for avoiding dementia? Well, there are strategies that may lower your risk, but they don't completely eliminate that risk. Just like I was talking about, we try to lower the risk of stroke, but we can never eliminate it. So things that are important are probably the thing with the best evidence behind it is physical activity, exercise. And the best time to try to avoid dementia in your 70s is when you're much younger than that, in your 20s or 30s or 40s. So a lifetime of being physically active lessens your risk of dementia. Socializing lessens your risk of dementia, it seems. So people who do things with family and friends regularly seem to be at a lower risk of dementia. Social isolation is a risk factor for dementia. Making sure that you can hear and see, because poor hearing and poor vision are risk factors for dementia. So somebody is making these things go up before I'm finished talking about them. So I wonder, I don't know, maybe that's automatic, but if someone's doing it, if you could stop doing it, I would appreciate it, because then I lose track of what the original question was. Making sure your hearing and your vision are good. Things that challenge your brain. And if you're in your 40s or 50s and have a very challenging job, that may be the thing that challenges your brain. But doing puzzles or games, learning a new skill, it's something like, for example, ballroom dancing, I think is an ideal thing because it's physical activity. There's a cognitive challenge there of remembering the steps, so you're learning a new skill, and that's good for your brain. And it's also a social activity. So I think it ticks off a lot of the boxes. A good, healthy diet is important. And the one with the best evidence behind it these days seems to be the Mediterranean type diet. And so those are some of the things we can do that I always mention to people to try and lower our risk of dementia, of getting it in the first place, and also of progression of dementia. So people with mild cognitive impairment, I'll always bring up those features with them and those things that may be helpful as well. Can double vision be a symptom of vascular dementia? Well, people with vascular dementia may have double vision if they've had a stroke in a part of the brain that controls vision. So yes, that can certainly happen. Let's see, what else do we have here? If the brain has had a lack of blood flow due to a missing feeder artery on the circle of Willis, would that cause vascular dementia? That's a very specific question. I'm not entirely sure what the person had in mind there. So maybe I'll skip that one because it sounds like some very particular case. Let's see. What have we got next here? I'm just curious how tea can be so powerful with dementia patients. I'm not sure what that means. How it changes their moods, etc. They can remember every single word to the music. Oh, maybe it was supposed to say music there. It says tea. They can remember every single word to the music, but little else. Yeah, isn't it amazing that you see it both ways? I've seen people with early, who were very proficient at music. I remember one woman who was a pianist, and that was one of her early symptoms, that she couldn't play very well anymore. And so that was an early thing. But I remember another man who played the guitar and another man who played the banjo. And even when their dementia was quite advanced, they were still quite good at playing their banjo and playing their guitar. And they often could sing the words to the music. We see that as well in people who've had strokes, who have aphasia. They often do much better with singing a song. So often we'll try to get them to sing something that's very familiar. Like you may see someone with a stroke who can't say anything at all, but you start saying happy birthday to, and they start singing along. Someone said, is the life expectancy for patients with vascular dementia different from those with mixed vascular Alzheimer's dementia, or does that depend on the patient's comorbidities? Yeah, so a lot of it depends on comorbidities. So what other illnesses does a person have will contribute to their life expectancy. The life expectancy for people with vascular dementia tends to be slightly shorter on average than those with Alzheimer's disease. But there's tremendous variability. I've seen people with dementia, that I followed for more than 20 years, and I see other people with dementia who, over the course of a year, have quite a dramatic progression. And I always get asked, what can I expect for the future? And it's really hard to answer. In an individual, you can talk about averages, but no one is really average. Someone asked, can excessive use of alcohol be a risk factor for dementia? Yes, it can. So people are asking about risk factors. That wasn't really the topic tonight, but I'm glad you're asking about those things. So yes, alcohol is a risk factor for dementia, as is smoking, as is high blood pressure, as is diabetes, as is physical inactivity, as is family history. So yeah, there are lots of, so alcohol is not really very good for the brain. And as you may know, about 3 years ago, Canada came out with new recommendations saying that 2 drinks a week is about the most that anyone should be drinking. Let's see what we have next here. I've heard some people say that many of people with Alzheimer's or dementia were once teachers or had other highly cerebral jobs. Is there any truth to this? Yeah, so dementia can affect anyone. We talked about risk factors. One of the reverse risk factors is education. So people with more education have a lower risk of dementia, but it doesn't mean they don't get dementia. I've certainly seen people with PhDs and specialist physicians and so on who've developed dementia, Alzheimer's, or other forms of dementia. But education does seem to be protective, and it may be because early in life, you've built up some cognitive reserve because you've really worked your brain by getting all this education, which is hard, that maybe the brain is a bit more resistant to pathology later on. There's a question here that's very specific. I'm not sure I have a general answer for it. And I'm not seeing any more questions popping up now. If anyone has any that they want to type in quickly, I'm happy to try and answer them. But if not, perhaps I'll turn things back over to Heather.
Well, I would like to thank you, Dr. Kurt, for speaking tonight, sharing your vast knowledge and experience. And I also would like to thank our sponsors, SGI and SaskTel Telcare. And again, to thank the team with the Alzheimer's Society who worked hard behind the scenes to make this presentation